Hey everybody, welcome back to the ECG channel. My name is Reed, and don't forget to download this PDF document down in the description below so that you can follow along. And yeah, let's jump into it. This is a fun one. This is kind of a funky rhythm. So we're going to start off by just kind of getting an idea of what's going on. We're going to look at the force, and so maybe come here to lead 2. You see you get this narrow complex rhythm. But what you'll notice is that we've got these early beats. So we'll have like an early beat there, and then a normal beat, and then another kind of early beat, and then a normal beat, and then we've got in green an early beat that looks different, and then a normal beat, and an early beat that looks different again, and then all those normal beats get to continue kind of uninhibited, we'll say, right? And so if I get a rhythm here that's narrow in that setting, and we kind of work through all this, right? So we'll take the rate, we'll check the rate here. We'll just see what are these rates. We'll see what the normal rate is. And we've got 300, 150, 100. This would be 75. So we'll call this maybe 85 beats per minute. Okay. And we see that in front of these beats that there are P waves, right? You see there are some P waves here. And so the red beats are narrow complex early beats. So we'll kind of put that here. That's our red beat. And the green beat are wide complex early beats, and they look different. So let's just evaluate our normal beats, and I think the normal beats are in blue, so we'll evaluate the normal in blue, and the normal beats have P waves in front of them. Those P waves, if you look at lead 1, are upright in lead 1, and they are upright in AVF. So these are sinus P waves, okay? The PR intervals seem to be within normal limits, right? They're in between 120 to 200 milliseconds. And the PR interval stays the same the entire time. I don't see any P waves without a QRS. I don't see any lengthening of the PR intervals with any drops, so that's reassuring. So my AV node is doing well, right? And since from a PR interval standpoint, we're going to move kind of fast through this, guys, so that we can get through all these little things. QRS complex, let's look at our normal QRS complex. It's narrow, right? If I look at the width, it's narrow. My QRS is less than 120 milliseconds. My QRS is isoelectric in lead 1, but it's upright in AVF, and so that tells me that it's going kind of straight down. So that's we call it the normal axis. We've got a normal QRS axis. If you wanted to do the math, that's positive 90 degrees, straight down towards AVF. And you can see R waves, maybe a little subtle R wave, if any, in V1. It slowly kind of grows to something more positive in V3, and V4, 5, and 6 look good from an R wave progression standpoint. Okay. And so then we look at our QT intervals, and QTs look okay, right? If you find R, midway point right here, you can see that T wave is pretty much done by then. So QT interval looks okay. So now it's our job to figure out the rest of this stuff, right? Let's figure out maybe why this ECG is acting up. And first thing I'm going to do is I'm going to evaluate for my pathological Q waves, my ST and T wave changes. Something that I notice is that when I do that, my inferior leads, especially lead 3, if you look here, here's baseline, and here's my ST segment. So we've got some ST segment elevation, and those T waves are kind of bulky. So we've got some ST elevation, and we have hyperacute T waves, predominantly in lead 3, but you see them here as well in lead AVF. You can see hyperacute T waves, meaning area under the curve is higher. And so we're actually getting some evidence of some inferior wall ST segment elevation, which makes me think maybe there is some infarction down in that inferior wall. So my eyes, they go to the high lateral leads for any reciprocal depression. So they go to lead 1 and AVL, right? Because we know that AVL and lead 1 are kind of reciprocal to leads 3. And I see AVL does have some subtle ST depression, right? And lead 1 has some very subtle ST depression too. And so we've got some ST depression in these leads. That's a little bit concerning for, what would that be concerning for? An inferior MI, right? Because the ST segment elevation in my inferior leads, right? That's what makes me think that. So kind of concerned for an inferior MI. What else are we concerned about here? We've got these early beats. Let's take a look at these red beats. So the red beats are narrow complex QRSs that occur early. So we know that they are 1, premature beats. And they're narrow. So they probably are either premature atrial contraction or premature junctional contraction. And when I look in front of it, I see this nice P wave, right? So a nice P wave in front of these red beats. And if you look up in V1, you can see that spiky little P wave in V1, right? You see that little spike, that's atrial deflection. You can look up in lead 2, you can see right there. You can see it up in lead 1, you can see it through all the leads, right? So this is a premature atrial contraction, right? That occurs times 2, twice. And then we've also got these premature wide complex beats that are here in the green. And so we say they're wide, but they're early, so they're definitely going to be a premature beat. And they're wide complex rhythms, right? Wider than the normal QRS complex, and they look different. And when I look in front of them, I don't see atrial activity. I don't see any atrial activity. So wide complex rhythm and setting of no atrial activity is going to be a premature ventricular complex. Okay. So we've got 2 PVCs. I guess technically this is a third. So we'll call this 3 premature ventricular contractions and 2 premature atrial contractions, and we've got evidence of this inferior MI. What's interesting about the PVCs, something that I don't really like, scares me, is that the PVCs, if you look in the limb leads 2, leads 3, leads AVF, my inferior leads, they're all negative. The PVCs are negative, meaning they're coming away from the inferior myocardium, and they're positive in my lateral leads. Well, if the focus that might have been infarcted, right, this inferior STEMI, if this was the area that was producing the signal, it would be going up and to the left. That's the direction of depolarization if that was the focus. So what I'm nervous about is that this person is having an inferior STEMI, and these PVCs, the PVCs are arising from the infarcted myocardium, right? So in the acute setting, you might be on a little bit more high of an alert towards any ventricular arrhythmias, right? You don't want this person to have like a VTAC episode or VFib arrest. So, alrighty, so let's kind of put this all together. What do we have? We've got a sinus rhythm at a rate of 85 beats per minute. We have ST segment elevation and some hyperacute T waves in the inferior leads with reciprocal ST depression in my high lateral leads, 1 in AVL. I've got 2 premature atrial contractions and 2 or 3 premature ventricular contractions that seem to be arising from the inferior portion of the myocardium. So, hope that helps. If you have any questions about this rhythm, feel free to comment and ask away. And if not, thanks so much for watching and supporting the channel. I hope you have a great rest of your day. Take care.